Hello everybody, my name is Chris Blunden. I'm one of the Endocrine Fellows here at Cincinnati Children's. I'll be speaking on the endocrine topic of growth today. So, as with any topic in medicine, it's imperative to understand normal before we start talking about pathological states, and growth is no different. So first, for the few slides at the beginning, we'll talk about normal childhood growth patterns throughout childhood and puberty, understanding the factors that influence linear growth in childhood and puberty, and using growth velocity to differentiate between normal and abnormal growth patterns. So it's important to understand as a background that growth is a continuous process and should be evaluated as such. So we'll focus our discussion more on pattern recognition than individual growth points in themselves. So for normal growth, we often use the World Health Organization chart between ages 0 and 2, and this chart is based on breastfed infants worldwide versus after age 2 and up through age 20, which is the chart that most of us are used to looking at. We use a chart based on American children. These charts are very similar for males and females throughout childhood until we reach puberty, when males achieve a faster pubertal growth velocity and thus usually achieve a, on average, higher adult height. So these are growth charts that we should all be very familiar with looking at. These are the CDC growth charts for boys and girls from ages 2 to 20 for stature and weight. And just to illustrate the point that I made a moment ago about normal growth being similar for young boys and young girls throughout childhood, I took a point at the age of 7 years for both boys and girls, and you can see that both of those points for the 50th percentile end up at a height of approximately 48 inches or 120 to 125 centimeters, regardless of which chart you look at. However, the slope of the charts on the boy side and on the girl side differ significantly once that pubertal growth spurt is achieved, and thus resulting in different final heights. So another important kind of baseline point to understand when interpreting growth charts is that a child's height and growth potential must be normalized for their genetics, and we calculate out a genetic potential based on how tall that child's parents are. So we should all be familiar with calculating a mid-parental height, and often this not only comes up on board exams, but should come up in daily evaluations when you're doing a well child check and evaluating a child's growth. So in review, to calculate a mid-parental height or genetic potential for a male, you would take the maternal plus paternal height in inches and add 5 and then divide by 2, or for girls or females, you would take maternal and paternal heights and subtract 5, divide by 2. This is in centimeters. If you were to use that instead of inches, the number instead of 5 that you would add or subtract would be 11. Mid-parental height or genetic potential is less valid if a parent did not meet their genetic potential. If there's a greater discrepancy between the maternal and the paternal height, so for example, if dad is over 6 foot and mom is under 5 foot, there's going to be greater variation in their genetic potential. And if parents have extreme tall or extreme short stature, again, that calculation is less valid for that child. And then to bring back a point I made earlier as well, that we are focusing on pattern recognition when looking at growth charts more than simply the percentile on the chart. So the first thing to look at is, do the measurements that you're looking at actually make sense? For example, this is a growth chart with obviously points that are extremely discrepant from each other and extremely difficult to interpret as far as what this child's growth velocity would be. And so if you see a growth chart and there's a point on it that doesn't quite make sense, then it's important to kind of re-measure, recalibrate so that you can make an accurate assessment and evaluation. And then the other point to make, besides just looking at the particular percentile, is the importance of looking at growth velocity. So a child might be on the shorter end of the growth chart, but growing with a normal growth velocity, as you see on the left. And this might be a very normal growth pattern for this child because they're maintaining the 5th percentile throughout the duration of their childhood. Whereas on the right, this is child's growth percentile is also low, but they're falling further and further from the normal curve and have a lower growth velocity than would be expected, and this is a more concerning condition. The other point to make is on the left, even though the growth velocity is normal, if the parents and the midparental height would predict that that child should be in, for example, the 90th percentile, then maybe growing normally along the 5th percentile is not a normal state either. So again, instead of looking at one particular point or one particular percentile, it's critical when evaluating growth to incorporate all of those different thoughts and all of those different points about on the growth curve. So as far as growth velocity, it's normal for any child to grow very quickly in infancy and early childhood and progressively slow down their growth velocity throughout childhood until puberty is reached. So this is an example of a growth velocity normal chart for a male. You can see that throughout childhood the growth velocity decreases until a pubertal growth spurt is reached, and for boys on average that occurs at approximately 13.5 years old at about 10 or 4 or a testicular volume of 10 milliliters. This is in contrast to females who achieve an earlier growth spurt at about 10 or 2 to 3 breast development, and at a slightly earlier age than males as well, at about age 11.5 on average for American females. The average age of menarche then is about 12.5 with a breast development of 10 or 4, and growth plate fusion is then achieved after that point. And then to finalize and kind of sum up the patterns or the factors that affect normal growth, there's several, including the nutritional state. Obesity or malnourishment can certainly either push forward or hold back a child's normal growth velocity. If you have overnutrition, that can certainly push things forward, versus undernutrition, where your caloric intake is more prone to go towards vital organ function and weight maintenance rather than growth. Genetics, as we talked about, parental heights and background as far as ethnicity certainly have an impact. If the parents are both 5 feet tall, you would not expect a 6 foot tall child from that set of parents. Any genetic syndromes can cause tall or short stature depending on what syndrome that is. Hormone regulation, so the timing and duration of puberty, thyroid hormone function, growth hormone function, which we'll talk about in a moment, have an impact on the child's growth. And then their physical and mental well-being. Children with chronic illnesses will not grow as well because they're using their metabolic function towards fighting illness and inflammation. And then children who are neglected or have depression or other chronic psychological conditions that can also affect their ability to achieve normal childhood growth, and all factors that should be taken into consideration when evaluating a growth velocity in children. So I would encourage you, I'm not going to to pause the lecture at this point, but I would encourage you to pause it on your own and do these calculations as practice for the midparental height for the following two patients. So first we have a 7-year-old male with a mom who's 5'3" and a dad who is 5'10". So when we calculate out that child's midparental height, you have a maternal height of 63 inches and a paternal height of 70 inches. Adding 5 because it's a boy and dividing by 2, and you get a genetic potential for this young male of about 5'9" inches or 69 inches. And the 2-year-old female whose mom is 5'2" and dad is 5'5". Again, we have 62 and 65. For the parents' heights, we would subtract 5 because this is a little girl, and divide by 2 for a midparental height of 61 inches, which would be equivalent to 5'1". So that sums up understanding normal childhood growth, and now I think we can move on to talking about abnormal growth or potentially pathological states that affect growth during childhood. So the objectives for talking about tall stature would be to create a differential diagnosis for common causes of tall stature and increased growth velocity, to plan an appropriate diagnostic evaluation for tall stature or increased growth velocity, and to use growth charts to distinguish between familial tall stature and other causes. So the first potential cause of an abnormal increase in growth velocity or abnormal tall stature would be precocious puberty and premature adrenarche. And the reason that there's an increased growth velocity in this condition is because of the sex steroids produced, either testosterone in males or estrogen in females, which cause growth plate turnover. Exam findings, which we should be familiar with, would be androgenization or estrogenization, so breast development in females, or body hair, odor, acne in males, also testicular enlargement, and a possible family history of early puberty would be an important historical point to ask. As far as the evaluation of these conditions, so for premature adrenarche, minimal evaluation is required. A bone age could be considered. For precocious puberty, up to and including all of these kind of listed tests to confirm your diagnosis: bone age, a morning LH, a GnRH stimulation test or leuprolide stimulation test, a testosterone or estrogen level, a pelvic ultrasound to look for the endometrial stripe in females, which should not be present or enlarged prior to puberty, and an MRI of brain to look for any cause potentially of early puberty in these patients. And treatment for this condition, again, is usually undertaken by an endocrinologist, but you should know that a GnRH agonist, either intramuscular or an implant, Supprelin is the brand name of that particular treatment, are used to suppress puberty in these conditions. So this would be an example of a child who had undergone an early puberty. You can see that they were tracking along the 95th percentile for growth, and subsequently at age about 7 or 8 years old increased their growth velocity to above the normal curve. And looking at their bone maturation and ossification on the right, you can see that there's some cupping and a sesamoid process present, which in a 9-year-old child should not be there. Hyperthyroidism is another potential cause of increased growth velocity, and this is due to increased bone turnover and lengthening. Exam findings in hyperthyroidism could include goiter, tremors, wide pulse pressure, oily skin and hair, hyperreflexia, and exophthalmos. We usually say in the endocrinology clinic that these are patients that you can walk in the room and tell immediately that this is the diagnosis, because they're so tremulous and kind of worked up and anxious. beyond a normal child. The evaluation of this condition would include thyroid function tests and TSH receptor antibodies to kind of clinch the diagnosis, and we usually treat this condition with either medication, surgery, or radioactive iodine. On the right, you can see a classic set of labs for a hyperthyroid patient with a completely suppressed TSH and a high free T4 and a positive antibody profile. Classically, you'll also see this picture come up, at least in the adult world, of exophthalmos and proptosis, and sometimes these patients require a vision evaluation as well. Klinefelter syndrome is a condition in which you have an extra copy or copies of sex chromosomes, and therefore an increased dosage of the SHOX gene, which leads to increased long bone growth. Findings in this condition include tall stature, testicular dysgenesis, gynecomastia, and a unicoid proportion. You may evaluate and diagnose this condition with a karyotype, a testosterone level, in bone health is also followed over time. It's a condition that affects several body systems, but from an endocrine and from a growth standpoint, it's often kind of the tipping point to make the diagnosis is the tall stature and the possibility of delayed or halted puberty. This condition, from an endocrine standpoint, is treated with testosterone as needed. And again, you can see on the karyotype here that there's classically an extra X chromosome, so there's a 47XXY karyotype, although other karyotypes may be present. This is kind of the classic one that generally shows up on boards and things like that. Typical phenotypic features of this syndrome. And then the last point for tall stature that I wanted to make is that obesity in itself causes aromatization, and the adipose tissue aromatase may drive bone maturation and prime the pituitary gonadal axis to an earlier puberty. And so because so many children in the United States are obese, you often see them growing at taller than their genetic potential, and this is often a reason why. And so it's something to keep in the back of our minds when we're assessing a patient. If they are taller than we would otherwise generally expect, that it's possible that their bone age is more mature and that they may go through an earlier puberty because of their excess adiposity. Moving on to kind of the more common parental concern, and certainly more common referral that we see in clinic for our patients from the general pediatrician, talking a little bit about short stature. The objectives that we'll talk about are identifying the most common causes of short stature and or slow growth velocity, plan the evaluation of a child with short stature or whose growth velocity is decreased, and to distinguish between constitutional delay, familial short stature, and other pathologies by clinical history and growth chart evaluation. Familial short stature should be apparent based on a low midparental height, as we calculated together earlier, without a decreased growth velocity. So the evaluation is purely clinical, and that's evaluation of the midparental height of the patient, the parents, and if possible, the grandparents. And if you consider the child's genetic potential, the normal growth for that particular child's background and ethnicity, especially if they're adopted. Sometimes it's not possible to calculate their genetic potential, and if that genetic potential is low, they have a normal growth velocity, there really is no treatment indicated in that particular case, and familial short stature is diagnosed. Constitutional delay of growth in puberty, or what are otherwise known as late bloomers, are also a common occurrence. These patients have a typical drop-off from the growth curve at age 1 to 3 and then reestablish a new normal. This can be particularly concerning if their midparental or genetic height is already low and then they drop off of their already low curve at that age. The constitutional delay leads to a prolonged phase of childhood growth deceleration because as everyone else is hitting their pubertal growth spurt, these children are still pre-pubertal and reaching the nadir of childhood growth velocity, thus increasing the discrepancy between them and their peers. On exam, generally about 80 to 90% of these patients will have a family history of constitutional delay or late bloomers, and it's usually a high yield question to ask if anyone was growing in the family past high school, especially first and second degree relatives. They will have delayed puberty, often appear younger than their stated age, and otherwise not have any concerning findings on their exam. They'll have a delayed bone age if you get an x-ray, and you can calculate their genetic potential based on that delay and potentially reassure parents. And the treatment is generally expectant management and reassurance. Particularly, this might bother high school boys if they appear much younger than their peers, and so after age 14, we will at times offer a course of intramuscular testosterone to try and prime the pituitary gonadal axis to start puberty if the parents and the child elect to have that treatment. This is just to reiterate, again, based on the growth velocity chart that we looked at earlier, that children with constitutional delay will reach a very low growth velocity of their childhood as their peers are reaching the higher point, but then you can reassure them that as everyone else slows their growth velocity, when they do hit their pubertal growth spurt, they'll have catch-up. SGA without catch-up growth, so about 90% of children who are born small for gestational age do have catch-up growth by age 2. The growth velocity in these children is often normal. It should be normal. And the 10% or so that don't catch up may be considered candidates for growth hormone if their predicted adult height is on the lower end. And this is an example of a patient of ours who never had catch-up growth, was born small, was started on growth hormone, and had a very nice response and was able to get back onto the growth curve. Hypothyroidism is another consideration with a poor growth velocity or short stature, and the reason for the poor growth velocity in this condition is because of slow metabolism and low bone turnover. The exam may be remarkable for a family history of autoimmunity, as Hashimoto's or autoimmune chronic lymphocytic thyroiditis is the most common cause of hypothyroidism in the United States. They may have fatigue, dry skin, hyperreflexia, goiter, or other symptoms of low metabolism. The evaluation should be, again, thyroid function tests and thyroid autoantibodies and treatment with levothyroxine as thyroid hormone replacement. On the bottom left, you can see a patient who had severe hypothyroidism at the onset with a very high TSH and a very low free T4, indicating primary hypothyroidism. And the same patient who had exhibited a decrease in her growth velocity down from about the 50th to 75th down to the 10th to 25th percentile was able to get back to her normal curve once thyroid replacement was initiated. Growth hormone deficiency is another consideration in the child with poor growth velocity and short stature. Growth becomes growth hormone dependent after approximately 6 months of age, so this is a diagnosis that at the earliest is often, unless there's some other reason to evaluate the growth hormone axis, is often not made prior to about the first year of life. These children may, if they have profound and complete growth hormone deficiency, have increased subcutaneous adipose tissue. They may have delayed dentition, they may have hypoglycemia because of the impaired counterregulation of growth hormone. They may have a decreased growth velocity, and they potentially could have growth hormone deficiency secondary to an intracranial process, and so it's important to evaluate these patients for intracranial pressure and vision. Growth hormone deficiency is evaluated by growth factors. IGF-1 and BP3 are generally our screening tools. Bone age, which should be delayed. A growth hormone stimulation test would be our second line if those are non-reassuring. And then, as mentioned, looking for any potential causes of the growth hormone deficiency would be important as well prior to treatment with daily or nightly subcutaneous injections to replace the deficiency. Another example of a growth chart of a patient who clearly had a very abnormal growth velocity and then was started on growth hormone with a very nice response to that velocity. And the reason that we do an MRI to look for any underlying cause of pituitary hormone, either excess or deficiency, again, is looking for any mass or craniopharyngioma, cystic process, tumor, and that way we can treat the underlying cause of that deficiency or excess. And then finally, last couple of processes I'll talk about here are Turner syndrome and undernutrition. Turner syndrome is a condition in which there's short stature due to missing X chromosome material. So in contrast to Klinefelter syndrome, where there's extra sex chromosome, there is a deficiency or haploinsufficiency of sex chromosome, and particularly the SHOX gene in this condition causing short stature. These patients have classic phenotypic features of lymphedema, cubitus valgus, widely spaced nipples, chronic ear infection, high arched palate, short metacarpals or metatarsals, nevi, ptosis, and the phenotypic range can be quite variable from having very little to none of these features to having all of them. This is a diagnosis that's, again, made by karyotype and should be made in girls with short stature with no other explanation, and a karyotype is indicated in all of those situations. And these patients, though they're not growth hormone deficient, are treated with growth hormone and estrogen at puberty as indicated, because many of them are unable to make estrogen on their own. These are the classic phenotypic features that you might see in this condition. And a classic karyotype with a missing X chromosome. And then finally, undernutrition. This is judged by body mass index, not just the weight percentile. So if the weight is low but the height is low, and the body mass index is normal, you can attribute poor growth to undernutrition. However, if the weight is lower than would be expected based on the height and your body mass index is low, then it's possible that the calories are going towards vital function and energy storage rather than height, which isn't necessary for survival. Weight loss and poor weight gain, in order to make this diagnosis, must precede the decrease in growth velocity. The kind of one of the counter responses of the body to try and conserve calories towards those other functions like weight gain and vital organ function are to become resistant to growth hormone at the level of the liver. So usually it's not optimal to evaluate for growth hormone function in children with low BMIs prior to getting their nutritional state in a better place. We treat these patients as it would be expected with a high calorie diet to optimize weight gain and increase their BMI. And then finally, to round out any evaluation of short stature that we didn't cover here, malabsorption caused by potentially celiac disease should be evaluated and ruled out. Chronic inflammation should be ruled out potentially with an ESR or CRP. Chronic disease, so kidney and liver disease, we can evaluate with a CBC and CMP, could be considered. Genetic syndromes like Noonan syndrome, Russell-Silver syndrome, Prader-Willi syndrome may also cause short stature. And then if we don't find a cause, the diagnosis of exclusion, we would consider a child with short stature and no cause to be ISS or idiopathic short stature. So thank you very much for your attention and for having me talk today.